intimately aware. I've asked two of the panelists to return at another date and re-empanel this panel so that instead of having two witnesses, we now have three. I particularly appreciate the patience of Madam Cito and Colonel Pucci and Madame Lalonde. Colleagues, as you know, if the bells start ringing, I have to suspend unless I have unanimous consent to continue. I am not going to ask for unanimous consent now, but I would like to ask, I will be asking for unanimous consent when the bells start ringing. And I'm hoping to at least get statements done and then go from there. So with that, I'll ask first Dr. Lena Tam Sado, and then after that Miriam Lafond, and then after that Colonel Pucci to have their opening 5-minute statements. So again, I thank you for your patience and look forward to what you have to say.
Thank you. Is the audio okay? Yes.
I think we're all checked out. Yep.
All right, thank you.
Good.
Good afternoon, Mr. Chair and members of the committee. Thank you for the opportunity to come before you today to speak about some of the work that I've been a part of. And that's to better understand the experiences of Canada's military veterans and their families, particularly during periods of change and transition. I come before the committee as a health researcher from McMaster University and the Canadian Institute for Military and Veteran Health Research. I am a civilian with no military experience, and I'm not from a military-connected family. I am, however, a registered occupational therapist with over 20 years of clinical and research experience. I'm here to share with you what we currently know about the experiences of members as they go through the process of releasing and shifting where they receive healthcare services. Doing the work I do, I often hear people asking what makes veterans and their families so special. Why should they be treated any differently by the healthcare system than me and my family? The answer is simple. Veterans and their families are unique because of the personal sacrifices that they have made to serve this country, and they should not be put at a disadvantage for that service, which is why my colleagues and I do the work that we do and will continue to do. My statement this afternoon is going to focus on two specific phenomena experienced by Canadian Forces veterans during their military to civilian transition, regardless of the type of release. The first one being is that there is no consistent mechanism in which health information of members are moved from CF Health Services into the civilian healthcare system. Unbeknownst to most Canadians, there is no dedicated healthcare system that provides services to veterans. Upon release, veterans are placed in the same healthcare system used by all Canadians, and thusly face the same challenges, barriers, and delays. For some veterans, they have pre-planned their inevitable transition to the civilian system by reaching out to primary care providers who may already be connected to them through family or friends, which does facilitate this process. However, for many, this abrupt stopping of services creates a real potential in the gap in their health care. For people with complex or chronic health conditions, this gap is even more severe. We hear stories about veterans who are left to put their names on countless waiting lists or who are forced to use walk-in clinics, urgent cares, or emergency rooms for routine care. Many veterans have shared that in cases when they are able to see someone, they need to prioritize, to choose which of their health conditions will be seen that day. This can be extremely tedious if veterans are living with multiple health problems. The second point I would like to highlight is what happens when veterans finally enter the civilian healthcare system. As I mentioned before, most Canadians are not aware that veterans access health services provided through provinces and territories. And it is therefore unlikely that these healthcare professionals and institutions are aware of what it means to be a veteran and how experiences in the military directly impacts not only the risks for certain health conditions, but also how veterans engage with healthcare providers. In other words, for the most part, the Canadian healthcare system, which includes providers, institutions, policies, and processes, do not have military cultural competency. This is necessary to provide veterans, and by extension, their families, with quality care that meets their unique health needs that have been shaped by military service. Cultural competency is seen as the ability to appreciate the differences among people, that each person is culturally unique and as such a product of their experiences, cultural beliefs, and cultural norms. Therefore, military cultural competency is the extent to which healthcare providers, such as myself, who are working with veterans and their families are aware, knowledgeable, and sensitive to the distinct needs and relevant issues related to them. And most importantly, what I need to do as an occupational therapist to adjust my practice once I know about their connection to the military. There has been increased efforts by Canadian health professional associations, such as the College of Family Physicians of Canada and the Canadian Association of Occupational Therapists, to create materials aimed at developing a military-specific knowledge base for their members. This is an excellent and commendable start. However, there's much to be done in training and certification of healthcare providers. I've been leading much of the work in Canada, trying to understand what it's like for veterans and their family members when they're receiving care in the community. In addition, I've also been exploring the experiences of healthcare providers to identify gaps in their awareness, knowledge, and skills to be able to be more culturally competent when working with members of the veteran community. Thank you again, and I look forward to our discussion.
Thank you, Dr. Tamsato. I've been remiss in not acknowledging that a former colleague of ours is in the room, Karen McCrimmon, former chair, yes. But welcome once again, Karen. With that, Madame Lafond, you have 5 minutes, s'il vous plaît.
5 minutes, please. Yes, thank you very much, Mr. Chairperson, and thank you to members of the committee for welcoming me here today. Myrène Lafond, and I manage the Crisis and Suicide Prevention Centre in Haut-Richelieu-Rouville. We're located in Saint-Jean-Richelieu, near the military base and the recruits and training school, as well as the officers' military college at Saint-Jean-sur-Richelieu. The centre has existed since 1993, and we have a telephone crisis and face-to-face crisis service for those who are considering suicide or who have made a suicide attempt. And over the years, we also developed our crisis accommodation centre. We have crisis beds in our centre, and the military base, when we set up these crises beds, contacted us and developed training and for suicide prevention. And all of these services are provided, including these crisis beds. So since 2015, we have been accommodating military recruits, as well as servicemen and servicewomen who need some time out to get through a particular crisis, whether it has to do with suicidality or some sort of psychosocial crisis. Our team is comprised of crisis interveners. They are bilingual and they have academic training in the field. There are a lot of service people who are Anglophones who stay with us. There is, in fact, one bed that is reserved for that particular clientele. And we have worked in collaboration with the Canadian Army in developing the services we provide. And all the servicemen and women who are accommodated in our crisis centre have to reach out to the medical service first and are evaluated and then referred to us. So instead of these individuals being hospitalized, it makes sense that they come to a crisis centre where they can receive the psychological support and the therapeutic approach that is required in order to get over that period of suicidality. It also allows them to take back control over their lives, over their suffering as well that they're experiencing. Now, the fact is that we are not military ourselves, and in a sense, that gives these servicemen and women an opportunity to take a step back and to feel free to speak to us about what they're experiencing. For the most part, these are people that have been uprooted, that have left their homes in order to spend 12, 13 weeks in Saint-Jean-sur-Richelieu, completely unfamiliar area to them, and that often leads to crises. And the fact is that given by virtue of the fact that we're not a military crisis centre, it gives them an opportunity to take some time out in that respect. We have very open communications with the military base. This is absolutely paramount to our minds, and it ensures that our centre runs smoothly. And over recent years, there's been a significant intake of servicemen and women from the military base. They are accommodated for a period of 3 to 10 days to give them enough time to either return to the military base or to be released, because it no longer makes sense for them to be members of the Canadian Armed Forces. So again, it gives them some time out, an opportunity to take a step back, to do what's best for them, and to make that decision in a very conscious manner at the end of the day. So that's essentially what I had to say to you, and I'd be delighted to respond to your questions.
Very much. Merci. Colonel Pucci, you have 5 minutes, and just say to colleagues, I see that some were wondering what our finish line would be. It's 6 o'clock, hard stop. 6 o'clock, hard stop. Colonel Pucci, 5 minutes, please.
Mr. Chair, distinguished colleagues, good afternoon. My name is Colonel Retired Richard Pucci. I'm a healthcare executive. I had the honor of serving in uniform for 30 plus years. I retired in 2016 out of the position of Deputy Commander, Canadian Forces Health Services. Prior to that, I served as the Chief of Staff to the Canadian Forces Surgeon General. Since retirement, I've had the pleasure of working with a multitude of veterans and veteran groups from coast to coast to coast. One of the primary challenges facing veterans seeking health services is the lack of access to care. In many cases, veterans must travel long distances to access health facilities, which can be tiring, expensive, and of course, time-consuming. Additionally, the waiting times for appointments are often long, leading to delays in treatment and increased risk of health complications. Addressing this challenge requires a paradigm shift on how primary care delivery is available to our veterans. What veterans want and need is access to care upon retirement. We need in place an independent body to help facilitate a smooth transition to the civilian healthcare continuum. Working with strategic partners, I am ready to launch a proof of concept trial here in the Ottawa area. I have developed a network of 2 healthcare facilities that are ready to be part of this revolutionary Veterans Healthcare multi-site trial. The first site is Beechwood Physical Medicine, which is an interdisciplinary clinic where clinicians use the best practices, evidence, and innovative solutions to assist our veterans experiencing physical and psychological pain and distress. The second site is the establishment of a veterans primary care clinic at the Tay River Reflections location in Perth, Ontario. I would like to reiterate that both locations are ready to take part in this innovative shift in delivering healthcare to our veterans. Both sites have generously offered up their infrastructure to support this most important shift in healthcare delivery for our veterans. The proof of concept trial would run over a 6-month period, with a goal of expanding to key sites across the country. I have the following 4 recommendations, if I may, Mr. Chair. Number 1, establish a Veterans Health Services Task Force. Initially, the task force would work independent and have no affiliation with Veterans Affairs Canada or the Canadian Armed Forces Transition Group. However, a level of synergy would be developed once the task force rolls out the proof of concept trial. The task force would report directly to this body or another entity as deemed appropriate by the chair. This task force will be made up of veterans with expertise from the healthcare sector, as well as representatives from across other health authorities and jurisdictions. Recommendation 2, I recommend that the Veterans Health Services Task Force develop a governance structure that would support the rollout of this model across the country. Number 3, recommend the allocation of funds to launch one of our program sites forthwith. As you may be aware, the program has been developed to cater to the needs of the veteran community, and we have completed extensive planning and groundwork to make it a success. The funding would be primarily used to cover necessary expenses to launch, including logistics, medical equipment, consultants, and staffing. And number 4, I recommend that the Veteran Health Services Task Force complete a detailed review of veteran primary care models of our allied nations. In conclusion, I want to express my gratitude to the members of the Standing Committee on National Defense, Health Service, and Transition Services for their leadership and their commitment to our military members and, of course, the veterans. Let us work together to strengthen these essential services and ensure that our men and women in uniform and out of uniform receive the care they need and deserve. Thank you.
Thank you, Colonel Pucci. Colleagues, the bells are not ringing yet, but I'm anticipating that they will be ringing. I intend to launch onto our first round of 6 minutes each, and then depending on how far we get, well, not depending on how far we get, to ask for unanimous consent to proceed. I'm rather hoping that we have unanimous consent, and then at some point we'll figure out what the timeline needs to be to actually vote. So with that, Madame Gallant, 6 minutes.
No, it's...
Oh, you are definitely not Madame Gallant. Sorry. Ms. Nyman.
Perfect, thank you. I'll start with yourself, Madame Tam-Sito. My first question, the impacts of serving on the mental health of our CAF members, or of the CAF members, have been often studied. Can you speak whether or not there's much attention being paid to the impact that this may have on children and families of CAF members?
Thank you very much for your question. So there is emerging research within Canada, particularly led from within research being done within D&D around the impacts of on children. However, we continue to be looking quite often stateside and internationally on that. We know that access looks different. Access to mental health care looks different here in Canada because there is a dedicated healthcare system for family members down in the States. So we're just beginning to look at that here in Canada. So we do know there's some indication there's been some preliminary research being done, but there's definitely needs to be more dedicated research resources for that.
Okay, thank you. And to complement that, as it stands, do you think that there are sufficient specialized mental health supports for the children and families of CAF members?
Absolutely not. So I'm going to be very blunt about that, simply because I come from, I have worked in child and adolescent mental health care prior to becoming a researcher myself. So I know in terms of our training what we have and what we don't have. I speak passionately about military cultural competency and the work that I've done around that. So what we do know is that there are unique stressors for military families and military connected children. What we don't know is how well the quality of care that they are getting in the community. So that is, to answer your question, no, they're not sufficient. I mean, children's mental health care is not great at the best of times for all Canadian children. However, for specialized populations, there's definitely a gap.
Thank you. And do you think that the challenges and barriers for healthcare and other basic services for CAF members and their families could serve as a barrier for new recruitment?
I think that is something that people probably don't realize as they're joining. So I think when we are recruiting folks, we need to provide them with an opportunity that, this is a career that'll span the lifetime. So quite often, new recruits that come in are not thinking about themselves at retirement, not thinking of themselves as having families. And I think that throughout the process, as people are going through the ranks, going through their training, that we within the Canadian Armed Forces are providing people with that insight, with that support as they consider.
Okay, perfect. Thank you.
Thank you.
Colonel Pucci, if you could address how readily available do you feel that mental health treatment modalities are made for former CAF members, and how do they transition to other supports following their time with CAF to ensure long-term support for veterans?
Thank you for that question. First of all, I'm not a clinician or a mental health care provider. I'm a healthcare executive and an operational planner. But I can just mention that there is a lot of issues, and this is from personal experience in meeting with our veterans out there, is that there's a huge gap from the time a member releases, goes out the back door of the Canadian Armed Forces and enters the civilian the continuum of healthcare. That gap is very hard, as with all Canadians. There's a gap out there for mental health providers. And unfortunately, I've talked to many, many veterans, and I've worked with many companies that are trying to put in place capabilities to support our veterans in the mental health realm.
Okay, thank you. Given the unique forms of stress and challenges experienced by those of positions of leadership within the military, can you think of any specific or specialized resources that currently exist now for their mental health?
Within the civilian sector? Well, I think there's a lot of new companies that are up and coming out there that are trying to bring forward new and innovative clinical capabilities to support the mental health challenges out there. But unfortunately, at the time, Veterans Affairs Canada is not allowing access to some of these new innovative technologies.
Okay, so how do we support them, and how do we support our veterans with potential burnout, and what is currently being done to support them in that regard?
Well, each veteran has a case manager within Veterans Affairs Canada. I had a case manager for the first 2 years of my retirement. I no longer have a case manager, so I'm basically on my own at the moment. But clearly, when I retired, I had access to a clinical psychologist. I had access to a care team before I retired, so I was quite fortunate. However, many members retiring today do not have the same level of access as I had. So there are gaps. However, there is capabilities that are now being developed out there to further support our men and women who retire.
Excellent, thank you. Madame Lafond, could you possibly address with regards to your experience working on the hotline? Do you currently receive frequent calls from CAF members reaching out to you on the hotline for continuous support?
Malheureusement.
Unfortunately, not. We get a lot of calls from the clinic that refers folks on to us, but in terms of servicemen and women who call us directly, no, unfortunately not.
Okay. To complement that question, how much awareness or training is provided to hotline workers surrounding the resources that would be unique to CAF?
All of our crisis workers get their 3-day accreditation and training to provide the crisis response for people displaying suicidality. And this training is recognised by the ministry. There's also the CREES training, which is also recognised by the ministry.
Sorry, I'm going to have to interrupt. The bells are ringing. Are these 15-minute bells or half-hour bells? Half hour. So can we get 20 minutes? 15 minutes? 20 minutes? Yeah, I was going to run it for another 15 minutes anyways.
Okay,
And then
15.
we'll suspend the vote
Okay.
and then do it that way.
C'est bon.
That agreed? Okay.
So ordered.
Okay. That's impressive. That's very impressive. Gee. Yeah. You've got about 15 seconds left, so.
I'll just ask quickly, are there a crisis response for CAF members after hours on the hotline?
Okay.
Nos services sont 24,
Our services offered 24/7.
peu importe.
So there's always availability on that hotline.
Madame Lambropoulos, 6 minutes, please.
Thank you, Chair. I'd like to begin by thanking our witnesses for being here with us today. And I'm going to start with Mrs. Tamsito. You mentioned that there's no consistent way for files to be transferred to the civilian system once the military signs off and retires. So based on what you've observed in your time observing and being in that system, what do you think are specific things that you would change in order to put in place a better system for transition, to make it flow better and to make sure that there are no gaps so that everyone receives the same transition?
I don't think we have enough time today for that. Just a couple of things off the top of my head. I don't think the responsibility currently lies at the doorstep of the member, which I don't think is fair. So a lot of folks that I've spoken to, they will take it upon themselves to do the groundwork before. I think the SCAN seminars that people attend, I think there needs to be much more emphasis on strategies that people can move forward to help with their transition. I think that physicians within right across Canada, but particularly those that are in military-connected communities, look at how they are prioritizing their wait lists, which I know is a big ask. I think there needs to be people that, before people retire, before SCAN seminars, people are attending SCAN seminars, to give them the heads up that this is the process of transitioning out. I think that the federal government needs to be talking to the provincial government in terms of finding a system to move accessing healthcare at the provincial level a lot easier for them, extending services, health services well beyond someone's date of release until they can find someone within the provincial government. Like I said, these are just a couple of the strategies that I have off the top of my head.
Would you be able to maybe put them down on paper and send them to our committee so that we have access to them?
Yes, I will do that.
Awesome.
Thank you.
Thank you. Mr. Pucci, I appreciate you being here as well and speaking about your own experience. You mentioned that when you were released, you did get certain services for a couple of years, that you were seeing a clinical psychologist, but that not everybody has access to this. So I'm wondering, first off, what factors played a role in you receiving these services? And secondly, why don't all members have the same?
Well, I think, thank you very much for the question. I think all members do have access. When they go out the back door, everybody is set up. They know exactly what their medical release data is. It's a 3B release, whether it's for a mental health disorder or physical disorder. So the CAF, and this is speaking, it's been 7 years since I retired, exactly to today. But at the end of the day, there's an opportunity where the attending physician provides you with what you need to do when you release from the Canadian Armed Forces. It's up to the member and then the veteran to seek that care. And the problem is, what my argument has been, is that it's hard to get from that back door to the front door of a new clinic because, there's just not a lot of primary care providers out there. And if somebody needs mental health care thereafter, they still need to have a primary care provider. Thus the reason for my argument about setting up this primary care hub for our veterans.
So I guess if I heard loud and clear your recommendation, and we're definitely going to be able to look at that and see if we can include it in our recommendations that we submit. But if there was a health services task force, what would be, in your opinion, based on your own experience, the main thing that they would recommend?
I think the recommendation would be to look at a cross-Canada governance system, to look at how we can facilitate the smooth transition from being in the military to being a civilian. The Veterans Task Force would look at each provincial healthcare system from coast to coast to see how we can better facilitate that move as well. So I think it would be setting up a governance structure to meet the needs of veterans and newly released members, but also at the same time concurrently dealing with provincial healthcare authorities to make sure they're aware of what we are doing.
Thank you. How much time do I have? A minute and a half? Okay. And so I guess the last question is a little bit broader. Mrs. Tam-Sito, I wanted to know if you can let us know what trends you've been seeing in mental health in the general Canadian population and how they compare to those that you've seen in the military population.
Unfortunately, I won't be able to speak to that. My research has been predominantly with the military populations. But from what I understand, the rates are comparable. However, what is striking is that the rates of mental health are usually connected to military service, where most Canadians, it is not directly related to their career choice.
And have you noticed that things have gotten worse of late, or what have the trends been in the time that you've been
I
there?
think generally speaking broadly around mental health reporting has increased over the years just because of awareness and decreased stigma. So I'll just leave it at that.
Madame Normandine, 6 minutes, s'il vous plaît.
Thank you very much, and thank you to all the witnesses for being in attendance today. I'd like to start with Ms. Lafont, if I may. I'd like to hear your thoughts about the management of a crisis before the Suicide Prevention Centre intervenes. How does a military base manage a recruit who's undergoing a crisis? Thank you very much for your question. Before we entered into agreement with the military base, the servicemen and women managed crises cases with the Open Office, which is the administrative office at Saint-Jean-sur-Richelieu. And that office, 24/7, is open. A serviceman or woman is able to go there, and they have a camp bed, basically, and they're being monitored 24/7 in the initial period. And that's to avoid hospitalization unless, of course, it's an emergency. And while the 41st Health Services Clinic is able to provide a service, and that's open certain times during Monday to Friday. But at all other times, it's the Open Office that provides assistance. When your partnership came about, how were those people in crisis sent to you? Was it through the Open Office or... Well, when we entered into the agreement initially, the servicemen and women were sent directly from the Open Office, and they didn't go to the medical clinic first. Unfortunately, there was a suicide that did occur, and after they were accommodated in our centre, the servicemen wanted to return to the military base, but it was our recommendation that they be sent to hospital, seen by a physician. It was a Saturday. There was no physician on site at the military base, and therefore that individual unfortunately committed suicide. Now, we did enter into an agreement after that incident. All servicemen and women accommodated in our centre have to have been seen first by a doctor from the base or from the hospital that referred the recruit to us in the first place for accommodation. And after that accommodation period, when the serviceman or woman is released, well, it's either the medical clinic for the military base or the hospital that takes over their care. We put that provision in place after the unfortunate suicide. So it's my understanding that after you entered into this partnership, there's a better medical follow-up of these servicemen and women who are in crisis. Yes, indeed, there's a better support offered and a better follow-up. Could you please elaborate on your collaboration with the medical clinic on the base, for example, in terms of information sharing when there is a serviceman or woman in crisis? Well, the communication channels are well and truly open, but when it comes to confidentiality, well, we always respect it when it comes to personal matters. But when it's a question of the life or death of a serviceman or woman, well, then confidentiality essentially has to go out the window in order for there to be information sharing. We have a tremendous partnership with the medical clinic on the military base. Our doors are open, the communication channels are open, and of course we inform the servicemen and women about the information that we are going to communicate to the military base medical centre as well. So there's transparency there as well. I'd like to hear your input about the funding formula for your service. What kind of funding formula have you and the military base entered into? Well, we're a grassroots community organisation that's funded by the provincial government, and the Canadian Armed Forces have insurance. It's the Blue Cross, I believe, and they pay us the same amount that would be paid to a hospital if a serviceman or woman was hospitalised in a hospital in Quebec. And we charge by the night, and we issue an invoice, and it would be the same cost as a crisis bed in a hospital. Well, the servicemen and women will get specialised services in addressing mental health issues, won't they, when they come and knock on your door? Yes, absolutely. We are a francophone community primarily in Saint-Jean-sur-Richelieu, but there are a lot of servicemen and women who are anglophones, and therefore our service is entirely bilingual. Unfortunately, in the hospital system, a lot of the staff don't speak English, so it's difficult for these servicemen and women in crisis to get the services they need in their mother tongue, and they feel increasingly isolated from a physical standpoint. Fine, but from a psychological standpoint, it's difficult when their mother tongue isn't spoken by the staff. So it makes sense, it's healthier if the servicemen and women can come to the crisis centre.
Normandine. Colleagues, Ms. Matheson's time will expire about halfway through the time we've agreed to. So if you don't mind, well, we can either not start or we could do her 6 minutes.
I want to head over to chamber vote.
Oh, you want to head over to the chamber? Are we agreed to that then? We'll suspend?
Come back and, yep.
Okay, then our time has expired, suspended until we return. Yes, until we meet. Okay, I see quorum. We'll resume our meeting. Ms. Matheson has 6 minutes, and then colleagues, once her 6 minutes is done, we're got about 25 left. I'll probably have to shrink the second round to get within the time limit of 6 minutes. So, Ms. Matheson, 6 minutes, please.
Thank you, Chair, and thank you to the witnesses for your patience through all of this today. I wanted to start with asking about to Ms. Tamsito. You've done a lot of research, as I understand it, on the impacts of operational stress, injuries, PTSD on women serving in the CAF. And I was wondering if you could talk about the differences that you see in terms of that research, how women are impacted by it, but certainly, of course, the service gaps that exist for women veterans in receiving the supports that in the trends that you see around that OSI and PTSD?
The majority of the work that I've been doing that would be classified as an operational stress injury acquired through work is related to military sexual trauma. So outside of that has been outside of my scope. So to be completely transparent, that's where the bulk of my research was around the impacts of military sexual trauma. Broadly speaking, around mental health challenges experienced by service women, broadly speaking, we don't have an understanding of how that impacts roles, how it impacts their identity, particularly around transitioning. So I know that a lot of individuals who identify as women have a difficulty accepting an identity as a veteran because of what they stereotypically see themselves, what society typically sees veterans as. So that's part of some of the stressors that women do experience as they transition. So I know that doesn't specifically answer your question because my work hasn't been specifically on operational stress injuries in women.
Okay. Well, certainly in terms of the PTS. Oh, sorry. Is the echo still? Okay, good. So certainly in terms of PTSD, I mean, that has a huge impact. Could you get into a little bit more around what you mean when you say they find it hard to see themselves as veterans, and how are there supports, are there programs? Is this more and more seen, and has the CAF D&D veterans VAC have they dealt with this in any way, or has it been identified other than by some of your research?
So I examine a lot around identity and change in roles and identities as people go through transition. So my work is around, stages of change. And as people are releasing from the military, they're changing from being a military member to becoming a veteran and essentially a civilian. For a lot of women, that shift is different because there is this social perception of what a veteran looks like, and that quite often doesn't match with how women appear in the world. And there isn't also that acceptability. So quite often, I hear stories about veterans who are women with the veterans plates, and people will approach them and ask, oh, did your husband serve? Did your dad serve? And then compounded by experience of military sexual trauma, where there is institutional betrayal, there is that difficulty for women to identify with the institution that has betrayed them, whether it be military sexual trauma or any other type of injury or illness that they may have acquired over the course of their career.
Certainly, in the work that I've seen, and incredible work that I've seen done on the streets in my hometown in London, Ontario, with veterans who are facing homelessness, there was a lot of that conversation about veterans overall, and these were mainly men, interestingly, but it was that identity and what they had in terms of their service, the institution that provided them the structure of that service, and then once they left service, what they weren't left with in terms of the identity that they had, but also the structure that they had. Is that the same for women as well in that role? As you're defining
it's essentially moving from one culture to another. And I know in London in particular, they have an incredible operational stress injury clinic. And I have colleagues that are there, and we are working on, how to support the healthcare providers to recognize that these identity shifts that veterans are going through, particularly those who are coming into the clinic with work-acquired trauma and illnesses, and what that means to them. So we are starting to develop those structures, and my particular area is around military cultural competency and what that means for healthcare providers, particularly with my colleagues at the OSI clinic.
Right. Well, we had also had previous CAF officials at this committee, and there's a bit of a confusion because they were talking about, we were trying to get into the operational stress injury support or social support systems that are provided with the OSIS. But that is not covered. Like they don't work at all in terms of sexual misconduct and that trauma. Is that correct?
People are going to the OSIS clinics because of the military sexual trauma. So it is a sort of subsection of a type of trauma which is very unique. So that experience is very unique. And we're just understanding how it's different than sort of other work acquired PTSD from service. So there needs to be concerted effort, and there has been. Again, I've been in communication with the OSI clinic in London, where they've identified that, you know, there is a subsection of people who are coming with trauma, but it's specific to military sexual trauma. And what supports and educations can we give to the service providers in order to help them? Because it's very important for service providers to understand the nuanced context of what it means to have, you know, acquired military sexual trauma, which is very different than civilian trauma.
Okay, we're going to have to leave the answer there. Thank you. Colleagues, if I do a second round and cut a minute off everyone, there's a good chance we'll be able to do it by 6 o'clock. So with that, Mr. Kelly, 4 minutes.
Colonel Pucci, you had referred to some technologies which were not being funded. To which technologies were you referring?
Speaking to treatment modalities that are currently out there. And as I stated earlier, I'm not a clinician. I feel very uncomfortable talking about treatment modalities because it's outside the scope of my area of expertise. However, many companies have approached Veterans Affairs with new technologies, new modalities of treatment, and they're currently being reviewed, but the process is extremely slow.
What about EMDR? Is that still being utilized, the rapid eye movement?
I believe yet again that's a very pointed clinical question, and I'm here to speak about primary care functional capabilities.
Right.
Thus, EMDR is not an answer. Not a question I'd feel comfortable answering.
So we have heard from ombudsmen time and time again. We need this seamless transition from the forces to medically releasing. However, your task force sounds good. But in reality, people are spread across the country, so they don't necessarily have the same people or even a linkage to the people who are dealing with them during the crisis stage and after they release.
Correct.
They have no one.
Yeah,
as
that's
a matter
correct.
Of fact.
That's the whole idea of the proof of concept period of 6 months. Whilst that period is ongoing, the task force would look at nodes across the country, say, for example, in Edmonton, Valcartier, Quebec City, Fredericton, where we would create that network, that hub of wellness for our veterans.
And then one of the insurers, I'm not sure if it was Veterans Affairs or a specific company, but they definitely dealt with all the veterans. They were receiving this EMDR from people who had qualified, but all of a sudden a certification was required. So these women and men lost their providers altogether because the people didn't have the new certification requirements, and they have families. They couldn't stop working and go back to school.
Right.
Is there no way that we can make the actual treatment they're getting seamless and not have to go to a lay person, because even having to explain what happened using regular military jargon, if they have to explain their whole story over again, they just become frustrated and they find a quick and a final solution to it.
Right. I've heard that story 100 times in the last probably year from other veterans and their families out there. Thus, the decision to cease the modality of treatment was based upon Blue Cross and Veterans Affairs Canada. We need to pose those questions to them, not people at my level that are dealing with setting up wellness hubs.
So could you tell us, how someone who has to medically release, what the steps would be under the task force? Like, what would it look like? What would a retiring or medically released soldier go through, especially if a trauma was involved?
Right. Well, it would be a seamless transition. So as he walks out the back door, or she walks out the back door of the Canadian Forces during their SCAN seminar, which my colleague mentioned earlier, they'd be aware of accessing these hubs. So the first thing the soldier would do is to contact the hub saying, I'm retiring on, say, the 15th of June, 2023. I'm looking for a primary care provider. I'm moving in, say, for example, the Edmonton area, St. Albert. Can you help me out? So the task force would be able to dig into its database and determine with its network of hubs in the Edmonton area what physicians are looking after veterans, and do we have a specific veteran clinic there with a family doc and a veteran physician assistant ready to receive that patient.
Okay, so the Beechwood and Tay River clinics, the only ones right now, and they're pretty well in the Ottawa vicinity
That's
anyhow,
correct.
which people from Ottawa already have access to providers. It's people out in Petawawa and Southern Ontario, far from Toronto, who don't have access to.
Right, but the people in Petawawa are quite willing to jump in their cars and drive to Tay River for treatment. We have veterans right now living in Petawawa drive to Orleans here in Ottawa to see Dr. Hans Young, who is the former Surgeon General, who runs a roster of 1,500 people.
Thank you, Ms. Gallant. Mr. Souza.
Thank you, Chair. Thank you for your presentations. I have a question. I'm not sure to whom it should go to. Maybe Madame Lafond, I'll start with you on this one, and maybe Tam Seto can respond as well. So there's an emerging conversation on the PTSD, right, versus moral injury. And how are these separate but closely related impacts of trauma experienced in the course of the military operations? And can you describe how these concepts differ and how treatment needs to differ?
Je laisserai Madame.
I'll allow Ms. Tam to tackle that question because we deal with crises, acute crises, and not PTSD. So I'm talking, we deal with suicide cases, but thank you for your question, but I'll defer to my colleague.
My apologies, sir. I'm not I don't diagnose, so I could not, in my scope of practice, be able to differentiate between PTSD and moral injury.
Oh, it's way outside my scope. Most definitely. I'm not a clinician, sir.
Chair, can you answer that question?
I can answer pretty well any question. You might want some better
I'll go with
information.
something else then. I guess I'll keep it more broad then in terms of how there's work being done to support defense research and the Canadian Forces Health Services Group. How can this research help improve the experience of those service members, veterans, and their families? And can the committee here, in terms of the steps to enhance this kind of research in the lives of the military members and their families, can you answer that more broadly?
There's research being done internally.
Yes.
And I know I've worked with many other wonderful colleagues within D&D, DGMPRA, doing this amazing research. Unfortunately, they don't have the capacity to answer all the questions that we need to. There's a lot of great research that exists out there that a lot of like I said, health associations are going to try to sort of develop military cultural competency among their members, among physicians, occupational therapists. However, they tend to be grounded within international context, which doesn't translate well over here to Canada. So, despite the efforts of, internal research, there's a whole network of us through the Canadian Institute for Military and Veteran Health Research that are trying to meet the demand. So just a very broad statement around research.
Colonel, if you have time, did you want to comment?
No, I would just defer to my colleague here. That's more along her lines of expertise research.
I have more time, Chair?
You have a little less than 2 minutes.
So we're talking a lot about mental health, and there's this mirror or difference from trends that are seen in the population of the military. Why is there a difference? Why is it more prevalent in the military?
Why is more mental health?
Yeah, why is it trends in the population? Like, we're seeing that mental health in the Canadian population as a whole, and it's being more evident, and it seems to be even more so with the military.
So I just want to reiterate my research isn't specifically on the mental health and well-being of serving members, so I can't speak to that. So I can only speak to sort of, what my statement was before around increased awareness, decreased stigma in terms of reporting. There is more dedicated research looking specifically within the military. Again, my research is predominantly around veterans and health services.
Thank you, Mr. Monsieur Brunel Duceppe, bienvenue.
Welcome to the committee. 1.5 minutes, please. Thank you, Mr. Chair. I'll try and be as good as Ms. Lenormandin, but I'll do my best. Do you get the sense that servicemen and women are more open in dealing with you than with the folks at the Military Medical Centre? Well, thank you for your question. Yes, indeed, there is a notable difference in terms of how servicemen and women deal with us. We are not a military context, and so it's a peer-to-peer relationship in a sense, equal to equal with the person who is in our accommodation. And they've come out of a setting that has contributed to their crisis, and therefore, in a sense, they're able to take a step back from that. And when they open up to us, there'll be no impact on their careers, on their advancement. They're entitled to not do well, to be in crisis, so that thereafter they can recover and get back on their feet. So they can open up to us without any fear of judgment or any ramifications down the track. And the information that we transfer to the medical clinic has to do with the safety of the individual who's been accommodated by us in our accommodation. So anything that's said in confidence as part of the treatment, as part of the crisis, remains confidential. And so they feel they trust you more. Is that what you're saying, ultimately? Yes, indeed.
Monsieur Brunel-Desep, 1.5 minutes. Ms. Masson.
Thank you. Ms. Tamsito, I just wanted to finish up. Within your research, can you talk to this committee what you see in terms of missing, in terms of those data points, reporting from the CAF, reports that you would like to see, from as an example, the Veterans Ombudsman had made a comment about GBA plus policy discussions that had been done apparently, and analysis that had been done but not released, not made public. Could you? Does that happen with D&D and CAF? Are those some of the points that you would say are missing, or just give us an idea of what you'd like to see?
Yeah. So I don't know if this committee can help out with this, but what we've been trying to do at McMaster is collaborate more closely and engage with D&D to do research with active serving members. The questions we ask are slightly different than what is asked within the research departments within the institution. So, there are systemic barriers for us as researchers in the civilian world trying to access military members. I think it's really important for us to be able to access active serving members, to be able to do longitudinal studies, to follow them along, to see what that transition piece looks like. So from a research perspective, it would be great if we had free access to the great work being done within D&D research departments. It would be great to get any information from Veterans Affairs to help inform some of the questions that we have. I think, the message that I hope everyone can hear from, research perspective is that, if we can work together more collaboratively, provide information, some open transparency with civilian researchers, we might be able to do better work together and inform us in the work that we do to ask the right questions.
Thank you, Ms. Masson. Am I to assume Mr. Kelly? 4 minutes.
Thank you. We're just coming down to our last few minutes that we'll have. So, Professor Tamsito, after your opening statement, the first question to you was about the adequacy of supports for CAF members' medical support. You were quite emphatic in your responses, said that they were not adequate. Do you want to take some of the time we have left to give the committee more, some concrete or specific examples of inadequacy of medical support?
Medical support upon release is definitely a challenge that we get before we can get into developing cultural competency in healthcare providers in the civilian world. We need to be able to get people through the door. Right now, people are being dropped off as we were saying here, people walk out the back door from the Canadian Armed Forces and they're left on their own. So there needs to be more people at this table discussing this issue. It is not a D&D. I spoke to the chair during the break and said that this is not a D&D issue. It is a Veterans Affairs issue as well. It is also a provincial and federal government issue. We need people at the table to develop seamless transition. It is not fair for veterans to have to go seeking out on their own for healthcare, particularly health issues that they have acquired on the job. And it is not fair for their families to have to advocate for themselves. They did not sign up for this. We, as Canadians, need to at least provide them with a support system that enables seamless transition.
Okay. In your research, do you know how many serving CAF members are discharged for different kinds of health conditions that could be treated with adequate resources? So let's talk first mental health, those that are discharged for mental health conditions that could be treated.
I'd like to believe that every health condition can be addressed and supported. Treated to what extent is really very subjective. I think what we need to first do is be able to identify how many people are releasing and when and how. So I think basic data points are missing. I know that.
Okay, so you don't have the
I have
numbers on that. Okay, what about for physical health conditions?
So just to speed up the conversation, I don't have specific data.
Colonel, do you have any comments?
I can provide a comment to that question.
go ahead.
I sit on the City of Ottawa as the Veterans Task Force currently, and right now the latest survey from numbers coming out of D&D to us, there's about 800 veterans in the Ottawa area without a primary care physician. 800.
Okay. Thank you. That's a response, I think, more to the first question.
Right.
And
I didn't want to jump in.
No,
I didn't want to jump in.
Feel free. That's important information for the committee. But on the second one, then, do you know? I guess I'm trying to assess whether, with the personnel crisis that we have in the forces, are there members that are discharging for that could have had either physical or mental disability treated to render them still able to serve? Are people being forced out for lack of access to health care?
Well, being the former deputy commander of the health services, I was quite aware of all of the capabilities, and we put our best foot forward. I think every man or woman that presented at a clinic across the country received the best medical care that was offered at the time. So I think whilst in uniform, I received outstanding medical care. And I think it was very adequate and meted all my demands, as well as the men and women under my charge.
Okay. Okay. Well, I can't get a question and answer in 15 seconds, so I'll cede.
Mr. Fisher.
Thank you, Mr. Chair. Thank you to all our witnesses for being here. Colonel Pucci, thank you for your service. I'm going to sound a little bit all over the place here because you've all made comments today that have sort of all interacted. Colonel, you talked about your experience after you transitioned, and you had said, I think you had 2 years, you had access to a care team. Is there a level of service that every retiring CAF member, every transitioning CAF member gets? Not suggesting that they actually take advantage of what's offered to them, but is everyone offered the same thing?
Well, it depends upon the terms of your release. If you have a medical release, you have access to Veterans Affairs Canada, who provide you with a case manager, who help you facilitate and maneuver through the healthcare system. If you're released on a normal, I think it's a 5A release, which is a normal release, if you have no physical or mental health conditions, you're just put out onto the street and you look after yourself.
Okay, and Mrs. Tamsito, you talked about some type of relationship between provinces, territories, and the federal government. I suspect you mean some type of bilateral agreement where a CAF member would transition out and that there would be some type of partnership between each, because we talked about your trial projects in Beechwood and Tay River. And then we used the example when Madam Gallant was talking about examples about Southern Ontario. But when you think about cities and towns across the country, and you talk about 2 trial projects, which I salute you for that. It sounds like a great idea. But what happens when it's somebody in rural Nova Scotia or northern BC?
Well, there would be access to technology through telemedicine. Okay, we could access that. We would have, say, hubs within the provincial jurisdiction where veterans could use telemedicine to connect with a physician.
And your thoughts on it? Were you envisioning like a bilateral agreement, province to province, territory to territory?
There needs to be a mechanism in order to where there's agreement across different jurisdictions and different ministries to be able to make that seamless. So right now it's piecemeal, and the responsibility lies at the doorstep of the veteran.
Are there any provinces right now that give rapid access or front-of-the-line access to transitioning veterans, transitioning CAF members into veterans in provinces? Who does it well?
I don't have an answer for that.
Don't have the answer to that? Okay, earlier you spoke in your opening statement about challenges, barriers, and delays, but then your time ended on your opening statement. Can you touch a little bit deeper on the challenges, the barriers, and the delays? Things that we may not have talked about yet today?
I think I did touch on that with some, and I will be providing a brief where things are a little bit clearly articulated because there are so many layers and it just needs to be a much more organized discussion than what I can sort of share right now.
Colonel Pucci gave us 4 recommendations. Do you have any recommendations, and is that something that you're able to provide us right now, or is that something you'll put in your written statement?
I'll put it in my written statement, but I think there needs to be this recognition that there is a system breakdown right now. So that's the first piece, is that we need to get the right people at the table to have an initial conversation of what that pathway of transition might look like. And then once they're in the door, having different groups of people sitting around in order to ensure quality of care.
I'm going to ask all 3 of you if you have a comment, if you wish to chime in. I've heard it said that it would be better for CAF members to stay in the CAF and stay in continually as veterans. And never transition out into Veterans Affairs. Basically combine the 2.
I don't have an opinion of how people should continue to get health services. I just feel that there should not be the gap that exists right now.
Okay, Colonel?
I don't think there's the capability. It's all about capacity building. And the CF, the Health Services, being the former deputy commander, we would not have the capacity to support veterans, whilst they were transitioning out or transitioned out of the military. If you look at the U.S. model, they have the TRICARE capability, where a veteran reports the same sick parade as a serving member does. We don't have 300 doctors in uniform. We have barely a handful at times. Okay. So I think that's the biggest challenge, is capacity.
Madame Lafond, I don't know whether you want to speak to that specifically, but I also was interested in your crisis beds. Are crisis beds only filled with military members? I wasn't sure if crisis beds would ever have an instance where there would be a veteran in there or somebody who's in the process of transitioning.
Very briefly,
Nous,
Well, for the most part, it's the population from our region. So they are mostly recruits that we accommodate. And on occasion, we have accommodated veterans and also, and I'll use the term, it was a term that was used, but they were on leave because they were working on the military base to train recruits. So those military service men and women were teachers and trainers of those recruits. And they were at the military base and they were dealing with mental and physical health issues, and they needed the services from us. They consulted us to get support. But that's extremely rare that we accommodate veterans or in-service military men and women, mostly recruits.
And it was suggested to me that I should read this statement given the subject matter of today's conversation. Given that the subject matter of today's meeting will deal with issues surrounding suicide and self-harm, I want to take a moment to remind all those watching that resources are available if you or someone you know is experiencing thoughts of suicide or self-harm. Staff can access the Employee Assistance Program, Resources are also available online at crisisservicecanada.ca, or you can connect to the National Suicide Prevention Helpline at 1-833-456-4566, or the Kids Help Phone 1-800-668-6868. I did, on behalf of the committee, want to thank you. Time management is always a bit of a challenge in this committee, but you have very graciously accommodated to the joys of democracy. And I want to thank you for your contribution to our study. It's very helpful. So with that, colleagues, matter is adjourned.